after that introduction and the two amazing speakers that came before me, I'm not nearly as funny as any of them, and I use notes. Because I work at CMS, and if I go off script, I get in trouble. So I'll just say that up front. But I just want to say good morning, and I'm really thrilled to be here with you all today in person. Our previous speakers talked about 1915B waivers and 1915C waivers and CFRs and regulations, and that trickles down to government travel. And so I didn't actually get my tickets till Monday morning, and I was really nervous that I was going to have to email Diamond and say that I'm going to have to be virtual. So I'm really excited that I made it. And I really want to start by saying thank you to John. You know, I started working with him as an undergraduate over 20, almost 25 years ago. I was trying to count the number of years yesterday. And he's really the reason that I pursued a career in public policy. And I've had some incredible opportunities, including the current one, to be a public servant. He's also the reason that my mother is still a little bit upset that I didn't become a doctor, but that's okay. I think she's going to get over it eventually. You know, and I attended the first TCOM conference years ago in Chicago, and it was so exciting to think that there were enough people doing this work and approaching measurement in this way to improve people's lives, and we could get them in a room together and get them all to come to Chicago, and it was just kind of amazing. And I can't tell you how I'm in awe of standing here today 18 years later and seeing the number of people that are here and the excitement and a podcast and a YouTube channel. I don't do any of that. So I'm like, I don't even know how to find any of it. And it's really, it's phenomenal. So thank you. And I'm really excited to have 30 or 40 minutes of your time to share a little bit about the work that we're doing at CMS and at the Innovation Center, which I know sometimes a lot of that work is really far removed, but a lot of the language that was already being used this morning, that Karen and Soraya used, like these are words that I think are becoming a part of the lexicon in healthcare and in behavioral health as well. And as we see these complex systems start to realize they've got to work together and communicate differently, I think John also mentioned the word infrastructure. And I'm hoping that the work that we're doing at the Innovation Center over the last decade and moving into this next decade of our work is really building that infrastructure for value. And when we can build that infrastructure, hopefully it brings different systems and people together to collaborate to meet the needs of the people that we all want to serve and work with. So today I'm going to start by giving you an overview of the Innovation Center, our mission and our vision. For those, some of you may be familiar with some of our models and our work, and others may not be, so I'll just do a little bit of level setting at the start. Then I'm going to walk you through our new strategy. As I said, we have a decade of experience under our belts. We're moving into this next decade, and under our new leadership with the new administration, we wanted to take a step back and say, what have we learned, and what do we really want to accomplish, and how do we want to drive transformation more broadly over the next decade? And so I'll walk you through that refresh, because I think that's where you'll start to see, I think, some of the synergies with your work and where we want to head at CMS. And then I'll talk to you a little bit about two value-based care models that we're currently operating at the Innovation Center. We have a lot in our pipeline that might be of interest to some of you, but I'm not allowed to talk about it. So I'll talk about the things that we are doing right now to start to hopefully help you understand what we do through our models and demonstrations. You may be familiar with some of these models at the state level. One is the Integrated Care for Kids model, or INC, and the Maternal Opioid Misuse model, or the MOM model. Both of which aim to address the needs of individuals with behavioral health conditions and their impact on children. And I know that John, for instance, he's been a resource to the INC team already over the years. And then I'm happy, if we have time, and hopefully we will, to take some Q&A, but I didn't bring my phone, so someone's gonna have to cue me on time. And then as we kind of go through the talk, I'll talk, and you probably won't remember a lot of what I say, but if you want to have a couple of takeaways, I'll start with those. I'll talk about our renewed vision, which is really to create a health system that achieves equitable outcomes through high quality, affordable, person-centered care. That sounds like a lot, and it sounds very aspirational, but at its essence, I think what it boils down to is putting beneficiaries at the center of our work. And for many of you, that's your day-to-day work. I was telling John this last night and Lisa this last night, that I feel so far removed sometimes from the beneficiaries that we serve at CMS. But if we continually remind ourselves that every policy decision, every model, every feature that we design a new demonstration or a model should be putting the beneficiary at the center of our work, then it aligns us, I think, around hopefully a shared mission and goal. So that's point one. So how do we actually do this from the seat that we sit in at the Innovation Center? It's really through payment and care delivery models and testing new payment and care delivery models. And that, again, I'll go back to the word infrastructure that John used earlier. That becomes the infrastructure through which this work, I think, can happen. And core to achieving that goal is to ensure that our beneficiaries are in accountable and longitudinal care relationships with providers that can meet their health, including behavioral health and health-related social needs. And that we want to use all of the levers that are available to us through our model designs and demonstrations to advance health equity. And I'll talk a lot about the different ways that we're doing that in some of our demonstrations and models. And then last, I think the last point I would want to say is that I think we at CMS also have a real opportunity to learn from TCOM. You know, many of you are pioneers, and John and Lisa are pioneers in orienting systems around people. And I met with April and John and the team at the University of Kentucky earlier this year, and I was interested in meeting with them to understand how they're actually operationalizing person-centered care. It sounds simple and it's a lofty vision, but it's really hard to orient an entire federal agency or the Medicare, the Medicaid program around that. And so how do you start to operationalize that? And I think we have some great lessons and experiences that we can draw from here. So for those of you that are not familiar with the Innovation Center, I'm going to start at the very beginning, and that's with our statute. The Innovation Center was established in the Affordable Care Act back in 2010, so we're about 11 years into being established. The statute explicitly provides the Centers for Medicare and Medicaid Services, or CMS, the authority through the Innovation Center to test innovative payment and delivery models. So John talks in his book, and I was reading parts of the new book on the way down here, about the business of management. So systems get the results they are designed to achieve, which totally makes sense. So we want to redesign the system at the Innovation Center, and we want to test ways to redesign the system so that we get the results that patients want to achieve. And I'll try to pepper in a couple of examples along the way as well. So the goal of our models really is to move the health system away from fee-for-service payments that drive or measure utilization, that somebody get X, Y, or Z, towards value-based payments that drive better health and outcomes, and that hopefully are aligned with the things that beneficiaries and patients and their families want to see. So the goal of these models is to, in the statute, what it says is we have to preserve or enhance the quality of care for beneficiaries in Medicare, Medicaid, and CHIP while spending the same or less. Because one of the goals of the Innovation Center when it was established was to help bend that cost curve and start to bring help control and manage federal health spending. If the model is able to achieve any of the three scenarios in the shaded gray box, the Secretary of the Department of Health and Human Services can expand the model, including expanding the model nationally, which, to be honest, in the first 10 years has only happened 4 times. You'll see we've run over 50 models, so it's a very high bar to meet. But there are a lot of other ways that our models and the work that we do in the Innovation Center is driving system transformation and sending market signals out for what the kinds of integration and collaboration that we want to be able to see in the system. That's really where our area of focus is in the next year. We want to be able to meet the criteria for expansion. We also want to be thinking about those other transformational impacts that we can be having. So defining innovation. At the Innovation Center, as I said, we test alternative payment models. Some of you may know those as APMs as well. There's a whole alphabet soup of acronyms. And the goal here is to give providers the incentives to deliver high quality and cost-efficient care. So APMs can focus on a specific condition or a care episode, so joint replacement, for instance, a specific provider type. We have a number of models that we run in the advanced primary care space, for instance. They can be community-based programs. We had an accountable health communities model that just wrapped up. It was a 5-year model that launched in 2016, ended in 2021. And if for any of you that are interested, we just had a paper come out on lessons learned from that model. It's really our first attempt at a social determinants of health model where thousands of Medicare and Medicaid beneficiaries were screened for social services. We've been able to develop an SDOH screening tool out of that model that's being used more broadly across CMS programs and is really being adopted by private payers as well. So lots of learnings there. So there's some different types of models that we operate. I told you we had a lot of models that we ran. So, and I think this is the most up-to-date one. So if any of you have the slides that I sent previously, I don't know if they get distributed, that might have some slight errors in it because this thing is always changing. But this slide lists every model that the Innovation Center has ever launched, as well as models that have been announced more in blue italics. And you can see here that the models are broadly categorized under these 6 different categories. which, to different degrees apply under our new strategic refresh, but I won't go through all of these. But you can see that there were a lot of seeds planted in the first decade, and lots of flowers bloomed, and there were lots of learnings. But this is a little bit, I'm setting up a segue into our new strategic direction, which is really like, having lots of flowers blooming is great, but we might want to pick the flowers that we want the most, or the ones that we think are going to be the best ones for where we want to go. So this is a map that shows you the geographic spread of where CMS has invested in innovation through the Innovation Center across the country. The orange dots show you where and how many sites are running Innovation Center models. The red squares show you where a model is being run at the state level. So you see we have a national reach to our work. This coupled with this next slide, I think helps show our reach. And really, to me, it's not only what have we done, but where's the opportunity? So what's the opportunity for our new model test to help build that person-centered health system, knowing that we've had a footprint that is pretty national over the last decade. As you can see here, we've reached many providers and beneficiaries across the country. Every 2 years, we have a report to Congress that we're statutorily required to submit. And our next one, hopefully, will be out on time early next year. But from 2018 to 2020, in our 2020 report to Congress, we shared that we served over 500,000, or we worked with over 500,000 providers, plans, and provider groups, and we reached over 28 million Medicare and Medicaid beneficiaries through our models. So that's who we are, and a little on where we've been, and I want to spend a little more time on where we're headed and the new strategy and the new vision, which was released last fall. So our goal is really, as I said, to build on the lessons learned from this first decade of testing value-based payment, and to use our model tests and innovation moving forward to really drive a more person-centered system and health transformation. So 5 objectives guide the implementation of our new strategy and vision, which I talked a little bit about. And I'm going to touch on each of these objectives briefly so you can start to see all the different pieces of what we're working on and where I think there's some synergy and overlap with the work that many of you are doing. Our first strategic objective is to drive accountable care. That results in the delivery of whole person integrated care with accountability for outcomes and quality as well as total costs. So what does this mean? This means that we're really focused on testing innovations and models that facilitate longitudinal, accountable care relationships between patients and providers. That means we have a real emphasis on advanced primary care. We know that's often the first place patients are gonna go, families are gonna go, and accountable care organizations, which tend to be larger, primary care focused, but their goal is really to bring different types of physicians and providers together to jointly take responsibility and accountability for a group of beneficiaries. I think you can think of this as making sure that patients have a provider that's quarterbacking their care across settings and across their care journey, and that they're working with other providers to make sure that patient needs and family needs are being addressed, and that the care that families and patients are receiving support their overall goals. And to bring accountable care to more beneficiaries, we're designing models to make it feasible and honestly more valuable. We need a value proposition to bring more providers into these kinds of payment and delivery approaches, including behavioral health providers. We're looking at creating new participation opportunities and incentives for ACOs and other model participants to partner with providers and community-based organizations in particular in response to their patients and community needs. And that'll be a good segue for me to talk a little bit about equity, but this is a huge area of emphasis across CMS. This is the #1 priority for Administrator Brooks LaSure, who started over close to a year and a half ago now, and advancing health equity. When she launched CMS's new strategy, agency-wide, our first strategic pillar is advancing health equity. And so for us at the Innovation Center, as one of the centers at the agency, advancing health equity is core to what we want to be doing differently, and making sure that as we're designing models, we're using all of the tools that are available to us to promote equity. The other piece is, we can't really improve healthcare quality without addressing equity and closing disparities and differences in outcomes and mortality, and everyone here is familiar with those stats, so this is really core to the work that we're doing. Unfortunately, looking back, we've learned that healthcare providers that are participating in our models have generally had fewer Medicare beneficiaries from underserved populations, and they generally include beneficiaries who are less likely to live in rural areas. So one of the things we're really focused on is figuring out how we reach a more representative group of beneficiaries. And again, to create that person-centered health system, we have to embed equity in all of our models. So one thing that we're really focused on, and actually was in Chicago a couple weeks ago at the National Association of Community Health Center Conference, where we realized we have not great participation from community health centers in our models. And if we're talking about reaching, again, more representative group of beneficiaries, we've got to find ways to bring those safety net providers, those FQHCs and those CHCs into our models. And so our model teams are approaching things differently. They're saying on the front end, first, what are the historical barriers to participation? What differences do we need to make from a model design perspective? How do we think about care delivery requirements? How do we think about financial risk? How do we, quality measurement? Teresa's nodding, how do we think about quality measurement, which is different for FQHCs, for instance? How do we do all of that on the front end so that when we're launching a model, we're announcing a model, we know that we've created something that hopefully allows more people to come in? So over the past year, we've actually released some redesigned accountable care ACO models and new models in the oncology space and others. They're all testing ways to advance equity. So I'll give you a couple of examples of how this concretely manifests. And two other things that John noted in his book is that we're at a point in time, I think, in our evolution in the healthcare system and the child welfare system where we're more able to build a person-centered health system today than we were maybe 20 years ago or 30 years ago because of two things. The first is collaboration, which I'll talk more about shortly, and the second is data. And so we need better data to achieve our equity goals. And a core piece of what we're doing is collecting self-reported demographic and social needs data. That's really critical to identifying community needs and really critical to designing interventions and policies that address those needs. And then hopefully over time, we can measure our progress towards decreasing disparities in outcomes in care. And so we've redesigned and announced some new models that are requiring that collection of self-reported demographic data, starting with an ACO REACH model that we have in our enhancing oncology model, but this is something that we are ramping up. Without good data, we're not really going to be able to chart the right path forward. And second, health equity plans can help providers identify and address the needs of their communities. So again, some of our new models and redesigned models are requiring health equity plans from our participants. So in these plans, providers and organizations have to describe the needs of populations in their communities, especially underserved populations that they may be caring for, identifying health disparities in their communities, identifying the interventions that they are going to put into place to address those disparities, and then how they're going to be measuring ways and then identifying ways to measure their progress as well. And then we're also looking at quality measurement, stratification of quality measures. I talked a little bit about our accountable health communities models. We're looking at tools to support not just screening, but screening and referral. Are we closing those referral loops when we've identified a social need? And then benefit enhancements as well to improve access to care. So for instance, one of our models, we just included a nurse practitioner benefit enhancement that increases access to some medical services that otherwise nurse practitioners can't order without physician ownership. So for instance, if a patient needs diabetic shoes or hospice care, that through this model, a nurse practitioner can qualify an individual to receive those services. So we're trying to be creative about, because at the Innovation Center we have the ability to waive certain Medicare and Medicaid payment rules and other kind of benefit rules. It gives us a little bit more flexibility to test some of this stuff and see if there's opportunity when it's successful to scale it more broadly into the Medicare and Medicaid programs. The third strategic objective is focused on supporting care innovations that enable the delivery of that person-centered integrated care that I've been talking about. And the goal here is to give, and data I think is central to this objective in particular. Our goal here is to give participants access to actionable practice-specific data. So Soraya and Karen talked about some of the data that was available over the course of COVID and some of the natural disasters that have hit Louisiana in terms of understanding what's happening out there in the field with patients. And so to the extent that we can, we have to do a better job of giving our providers access to actionable practice-specific data at that point of care. Otherwise, it's not very useful to them to meet their patients' needs and then make sure that they're improving over time. We're thinking about payment flexibilities. I talked about the benefit enhancement, for instance. Those are the kinds of things we're looking at embedding in our models to facilitate more seamless and integrated care for beneficiaries. We also have a learning and diffusion group at the Innovation Center. And they put together learning systems for many of our models. And so it brings all of our model participants together in a regular space during the implementation period of a demonstration to really be learning about what's happening out there, what are some best practices, what might not be working. That information often then gets communicated back to our model teams who are operating the model so that we can also make real-time adjustments and be responsive to the experiences out there. But those peer-to-peer learning collaboratives are really essential to sharing best practices and, again, helping sustain transformation beyond the period of a model or a demonstration. Our fourth objective is addressing affordability. So I talked at the very beginning about our statutory mandate, which you see is pretty focused. There's a huge focus on reducing federal health spending, and that's often what a lot of people focus on when it comes to the Innovation Center. But we know there's also a lot more we can do to address affordability by addressing healthcare prices, reducing duplicative or unnecessary care through our models, increasing access to high-value care, advanced primary care, preventive care, behavioral health services, and then improving referrals to high-quality specialty care as well. And I think this is, again, a big emphasis across CMS right now is how are we making care more accessible and affordable to beneficiaries. This is a really big issue given what healthcare costs look like in this country, whether you have employer-sponsored insurance or even Medicare beneficiaries, out-of-pocket drug costs. These are really big issues that are facing families today. And so even if the Innovation Center historically has not been very focused on individual affordability or patient affordability, we have a lot of levers available to us in our demonstrations and our models to find ways to advance affordability as well. And then the other thing I'll say here, for many of the populations and the communities that you work in, it's not just that the direct costs, because they may not, not everyone faces a copay at the point of service, but it's those indirect costs that really matter when people are trying to navigate these really complex systems. And I, remember one story in particular when I was completing my pre-doctoral internship, and I saw patients in this gorgeous new clinic that had been built on the water in a large city. It was beautiful, and I was like, wow, I can't believe I'm gonna be seeing patients here. But the children and families I worked with were all Medicaid beneficiaries, and they often had to take multiple buses across the city to get to this clinic that really wasn't very accessible to them. And I had a mom in particular who was a line cook who had a 4-year-old son that was very aggressive at school, and they were trying to see me, and they were trying to make their appointment, but she's navigating, working a shift, having 3 kids, and picking her son up from school and then taking the bus to try to get to this clinic. And it's a small example, but even though, again, they didn't have a copay at that point of service, the indirect costs to them were quite high of trying to get to this one intervention that they needed. And so those are the other things that we are working really hard to understand better from the perspective of beneficiaries and families, that burden and that cost of navigating a system that's so complex, and how do we at the Innovation Center build models that hopefully reduce some of that complexity. And the last objective, our fifth and final one, is focus on how we're going to partner to achieve system transformation or collaboration, to borrow from TCOM. To achieve our vision, we have to collaborate with patients and beneficiaries, providers, health plans, employers, and states, among others. And I'll talk about our 2 state-based models, and you'll see how complicated some of these partnerships get, but that we really need them to be able to move the needle and to test the things that we want to. I think most importantly here, what I'll talk about is our work to strengthen our communications and engagement with beneficiaries and beneficiary groups. It's tricky when the Innovation Center is running models because we're not enrolling beneficiaries, we're enrolling providers that deliver care for beneficiaries. And so you're almost one step removed from the beneficiary themselves. And so one of the things that we really did as we looked back was say, if we want to center our work again on beneficiaries, we've got to get closer to those beneficiary advocates, beneficiary groups, and beneficiaries themselves. And actually just on Tuesday, we held a listening session on person-centered care and how at the Innovation Center, some ways that we're trying to operationalize that at the Innovation Center. It's really hard to do at that kind of agency level. I mean, it's hard to do even at a systems level. And so one of the things we shared publicly was our beneficiary engagement strategy, which involves integrating beneficiary perspectives across the life cycle of our models. So when we think about that, it's like when we're thinking about a new model concept, what is it that beneficiaries, patients, and families need? And are we going out and talking to experts, talking to beneficiaries themselves, talking to beneficiary groups to really understand if we were going to do something in the behavioral health space for this, to address these issues, what is it that patients would want to see? What are the barriers that they're facing right now? And then are we using our learning systems during implementation to continue that dialogue with patient groups and beneficiaries to understand, we had this theory of change in mind at the beginning. Is that theory of change actually manifesting itself? Are we seeing those changes in quality and care experience that we were hoping to see? And then all the way through to evaluation. One of the things that we have to do is evaluate all of our models because of that potential for certification and expansion. And so we want to be able to focus our evaluations more over time as well on the beneficiary experience, but we want to be able to pull all of that through across the life cycle of our models. And then the other piece of our person-centered strategy that we shared was improving the way that we're approaching quality measurement, so that we're including more patient-reported outcomes and patient-reported outcome measures that hopefully capture what is meaningful to patients and actionable to providers as well. The other piece of our work here is that we really want to be engaging with stakeholders, again, as we develop, implement, and evaluate models. This is really true for some of the state models I'll talk about later. We have some new state-based models that we're considering right now and working on. And we're really trying to, on the front end, work with states and former Medicaid directors and current Medicaid directors so that we are designing with a level of complexity that's appropriate for the challenge and not overly complex so that states have difficulty implementing what can be sometimes very complex models. And then the last thing I'll say here is that, transformation happens very regionally. I'm just listening to the journey that Louisiana has been on over the last decade. A lot of transformation is state-based and regional. And we know that at the Innovation Center. And we actually recently, through a public-private partnership called the Learning and Action Network, launched the state transformation collaboratives in 4 states. And they consist of, these state transformation collaboratives include payers, providers, health systems, purchasers, patient advocates, community organizations, and many times the business community as well, working together to develop locally focused approaches to addressing the needs of state populations through alternative payment models and value-based payment contracts. We really hope that these state transformation collaboratives create opportunities to inform our own model development and testing, and that hopefully our models can then also be part of and support that broader regional transformation. So I'll go through this quickly. To really achieve the goals under each of our objectives, we're focused on a couple of other key changes at the Innovation Center. I talked a lot about strengthening our communications with stakeholders and integrating patient perspectives. We've held a number of listening sessions over the last year since our strategy refresh launch. I think we've had about, on average, 1 a month. We just had one on Tuesday. We're planning to continue that. I think it's really important. Even though they're webinars and they can feel a little bit impersonal, this week's we had about 1,000 people registered, and so there's a lot of interest, and allows us to be able to share information, to be able to hear from experts depending on the format, and then we get a lot of Q&A, and it really helps our teams understand the questions that are bubbling up on the ground, and so we're going to continue to do those. Second, there's a whole research component, which is a huge part of TCOM as well. Achieving system transformation is going to require more dynamic generation of learnings for our models. So we have these evaluation reports that are statutorily mandated. They're wonderful. They have a lot of information, but they're hundreds of pages and quite dense and often very hard for people to access. And they serve their purpose, and they, again, we get a lot of information about impacts, and it includes quantitative and qualitative analyses as well. But we want to be able to supplement these evaluations with insights from external researchers. We think there's an opportunity here for us to be able to generate more dynamic learnings from our models. And I think some of this work is naturally a part of the TCOM community, that dynamic generation of learning. And so this is something that we want to be able to do more of at the Innovation Center. I think that is really critical for collaboration and kind of continual improvement of the work that we're doing. And then also I talked a little bit about our statutory mandate and how we want to be thinking about transformation moving forward and capturing the impacts of our work. So our North Star will continue to be testing successful models that can be expanded, per our statutory mandate. But we also want to mind the other impacts of our models that may not, they may not rise to meet the criteria of expansion, but we know that they are nonetheless contributing meaningfully towards health system reform. And so this could include things like how our models impact beneficiaries. So in terms of patient experience, quality of care transition. So in particular models, how did patients fare when they had to move from the hospital to a post-acute care setting or hospital to home? Do they have access to home and community-based care? So those are the kinds of things from a beneficiary perspective we want to start to capture more systematically and then understand whether or not our models are impacting those dimensions of care that matter to patients. We also want to better understand how our models impact providers in terms of care transformation. Did we improve their ability to change the way that they're delivering care? I had a site visit that I did back in July, also in Chicago, and met with one of our ACO participants, and they took us to a primary care clinic that they were working with. And they had been in practice for 30 years, and around the time of COVID, really felt like they were gonna have to close their doors. And it was a primary care practice that saw, multi-generational families. And they started working with this accountable care organization that's in one of our models, and they said it allowed them to keep their doors open, because what ended up happening is they came in and they were able to provide care coordinators, social workers, help support behavioral health needs, really provide that care delivery and population health infrastructure within that practice, and the extra support that they needed to keep their doors open. And I asked them, I said, what was your kind of workload like? Or, how many patients did you see in a day? Because that's kind of an easy question, before and after. And they said, well, we used to see about 25 to 30 patients a day. Now I see 10 to 12, and I really get to spend more time with my patients. And I have a care coordinator that I work with, and so I know so-and-so just got this medication for their, early onset dementia or X or Y. And, those are the kinds of stories that I think bring this to life, that when we're able to create the right incentives and pathways in our care delivery infrastructure, it allows providers to do the things that they want to be doing as well. And so that's one dimension of how we want to be able to measure our model's impact beyond just cost and, at a high level quality. And then we also want to understand, you saw our models have a pretty national reach. And over the last decade, a lot of the work that the Innovation Center does get picked up, has spillover effects, and does get picked up by private payers and others. And so we want to understand how our models are impacting markets, through factors such as, are we creating new linkages or relationships between different types of providers? Are we looking at successful elements of our model spreading to other payers? And what's the scalability of our work, especially our state-based work, to other regions or payers as well? I'm gonna end the overview with a vignette on what person-centered care can and should look like for our beneficiaries. So I said, if we align our care delivery and payment incentives, we can really start to reorient the system around the needs of a beneficiary. And I think this is just one story from a beneficiary in one of our ACO models, who you can see has multiple chronic conditions, lots of high ED use, and because of the payment flexibilities, the care delivery infrastructure that this model was able to provide, all of a sudden you have this, this beneficiary with multiple needs getting in-home visits, coaching to help improve their use of the ED. You have better follow-up with primary care provider and outcomes. And I have a handful of these kinds of vignettes. I picked this one, but there's others as well that allow beneficiaries to get their behavioral health needs met. You see social workers and caseworkers and care coordinators working directly with families to make sure that the entire system's needs, the family system's needs, are met as well. I want to talk a little bit about our Inc. model. And the Inc. and models in particular may be of interest to you all here today. And for any of you that are familiar with this model, I think Inc. is now operating in 7 states. I'd welcome your feedback on what's working and what isn't, and what we can do to improve. I hope you can tell that we're always in learning mode at the Innovation Center, and so sometimes we get an earful from stakeholders and participants about all the things that they don't like. And we do our best to say, even if we can't correct something now, how is it going to influence our work moving forward? Inc. serves as a local service delivery and state payment model for children covered by Medicaid and CHIP. Has a focus on children with or at risk for developing significant medical and behavioral health needs, including opioid and substance use. Over the course of 7 years, so it's a 7-year model, the model aims to achieve 3 high-level goals of improving child health services, reducing out-of-home placement and inpatient stays, which I know is a goal for many folks here, and creating sustainable alternative payment models that can support the system of care. So again, it goes back to how do we align care delivery and incentives, but also in a way that's sustainable over time. So why the Inc. model? Inc. was built on evidence-based research and stakeholder feedback. One of the ways that we often collect stakeholder feedback, obviously, is through meetings, but also through official requests for information that go through the Federal Register. And it's a way for us to, especially when we're developing a new model concept, sometimes teams will use the RFI process to gather feedback, and really does inform how we think about building a demonstration on the front end. So this graphic really summarizes how the Inc. model aims to address existing child health challenges and priorities related to early exposure, behavioral health risk factors, fragmented health services, which often lead to late diagnoses and treatments in higher cost settings, as well as limited, which we know are especially difficult for children, and as well as limited infrastructure investments to coordinate and collaborate across sectors beyond healthcare. So that's another big area of focus for our models. Is we know that many of our beneficiaries have social needs and health-related social needs that impact their outcomes, and so we're doing a lot more work in that space. How are we connecting our primary care providers, our ACO providers, our behavioral health providers, and others to those community-based organizations and social services organizations? And Inc. is probably one of our first models to really, is really a model that we can learn a lot from in that regard. It's been ahead of the others. In response to these challenges, the model sees opportunities to promote early identification and treatment of priority health concerns like behavioral health. We see opportunities to integrate care coordination and case management of both physical and behavioral health services. And we see opportunity to support obviously the development of pediatric alternative payment models. So to the extent the model is successful or we see successful features, it could be something that gets picked up in other places by other payers or states as well. So I talked a little bit about complexity earlier and how many different systems have to come together, especially for our state and Medicaid models. And so I'll walk through some of these pieces here. The lead organization for Inc. is a community integrator that's responsible for aligning service delivery within the payment model. So we have a lead organization for all of our Inc. grantees. The lead organization engages community partners and executes all of the data sharing arrangements that are going to be needed to operationalize the model. Next, we have the state Medicaid agency. The state Medicaid agency in Inc. is responsible for providing data on the attributed population, so the beneficiaries that are attributed to or aligned to the model. They're responsible for securing any necessary state plan amendments or Medicaid waivers, which is no easy task. Working with CMCS to make sure you've got the right waivers. Do you need a waiver? Can you go through a SPA process? And then the state Medicaid agency is also responsible for implementing the alternative payment model itself. And I'll note that both the lead organization and the state Medicaid agency in this case were eligible to serve as the Inc. award recipients. So different states, I think, did it different ways. And then the third and final key Inc. partner is the Partnership Council. And that council is comprised of representatives from core child service providers, community stakeholders, and payers. And they're really responsible for developing the processes for managing that care coordination. And I'll say one of the other things, especially with our emphasis on equity over the past year and moving forward, as we're thinking about new models, we're hearing a lot from stakeholders and beneficiary groups about how we are integrating the community voice into our models. That as we are thinking about implementing our models, how are we not only integrating the patient voice, but community needs as well. And I think Inc. and some of our state models, we have another one called Chart, have these community transformation plans. And so those are places where we're looking to learn a lot and to see what is working in those state-based models to see what else we might be able to scale as we move forward. Some of the requirements in terms of the core child services in Inc. Award recipients are integrating the coordination of core child services in their community. Integrated care coordination features coordination across multiple child and family serving systems to facilitate ethnically, culturally, and linguistically appropriate care. And I want to emphasize that each community partner listed on this slide and the next slide are entryways in determining a particular individual's or family's need. And then there's also a set of, so those were the core services. These are the recommended optional child services that award recipients can also implement. They can create a standardized comprehensive needs assessment process. Think of the CANs, that could be initiated by the caregiver or the service delivery provider. Folks before me also talked about law enforcement and juvenile justice. And so there's also opportunity for those states that might be a little bit more advanced or have some of these foundational pieces in place to bring these other partners to the table as well. The last thing I'm going to talk about is our MOM model. This is another important model focused on behavioral health conditions among pregnant women. It's the maternal opioid misuse model, or MOM. Pregnant women with opioid use disorders require care from a variety of provider types, including primary care, maternity specialists, behavioral health workers, and clinicians that offer medication-assisted treatment for OUD. And this was a model that was launched under the previous administration, but given the opioid epidemic, was a place where we felt like there was real need for integration and testing, and we've continued this model. Unfortunately, it just named a number of providers that are needed to care for a pregnant woman with an opioid use disorder. But these providers seldom coordinate or have the capability to share data. And so they're also rarely in the same location. They're all very different providers dealing with usually very different populations. And often, especially in rural areas where we know the opioid epidemic has hit rural areas especially hard, there just flat out aren't enough providers to begin with. And when we think about maternity deserts now as well, and the lack of substance use treatment in those areas. And so all of these things are really serious barriers to, obviously, to quality and to patient access and patient recovery, which is what we all would want to see. And there's also, so that's kind of the problem from the patient perspective, but there's also immense costs to the Medicaid program. Pregnant women with uncontrolled opioid use disorder more often have babies that, not surprisingly, need a neonatal intensive NICU stay or other specialized care, and the costs associated with that are high. And if we can do a better job of supporting these women and making sure we're getting them the right care at the right points in time, we should hopefully be able to avoid some of these costs as well. This diagram here represents kind of the overall structure for the MOM model, with the pregnant woman, hopefully the beneficiary, the patient in the center, receiving all the different types of care that they might need. The maternity care, obviously, the opioid use disorder treatment, behavioral health, and primary care as well. And you see they're all overlapping to indicate integration. One doesn't, there isn't a clear line between often where one ends and another service type begins. And supporting the model are state Medicaid agencies, which were awarded funds through cooperative agreements. And then they work with hospital systems, managed care organizations if they have them in their state, and other care delivery partners as well. So that's the overall framework. Some of the milestones and measures. MOM awardees can earn up to $500,000 in each of 3 performance periods at the end of the model. They do so by they can earn these awards by reaching certain benchmarks on the 5 milestones that are listed here. The initial payments are awarded for complete and accurate data, and each milestone transitions at an appropriate point to a performance-based monitoring measure. The milestones were chosen to align with the overall model's goals. So beneficiaries, how well are we engaging beneficiaries in treatment for their opioid use disorder? They have options as to the treatment types. Are we finding the right treatment that's working for them? Through the model, we monitor their confidence and beneficiary confidence in managing their own health through something called the Patient Activation Measure, which some of you may have heard of, or the PAM. And over time, working to really improve those scores. And it's not just a measure. The PAM is really a mechanism for engaging beneficiaries. And then ideally, those that begin pharmacotherapy continue throughout the pregnancy and potentially beyond, making sure that we're achieving milestones around appropriate postpartum care, including, and then improving outcomes for current and future pregnancies as well beyond the postpartum period. So collaborative partners, you can see we rely on partners, and I think that's kind of tried to sprinkle this in throughout the remarks, that we rely on partners across government and states to do our work. Because this model in particular is so directly connected to Medicaid, we work very closely with the Center for Medicaid and CHIP Services at CMS during development, and our team continues to meet with them regularly because we want to be able to understand state progress and really understand the sustainability of this model over time. We also work with our Office of Grants Management and others. We are currently doing some work, again, I said, in the community health center space, so we're working really closely with the Health Resources and Services Administration that oversees the FQHC program. We're thinking about some new work in the behavioral health space. We're really working hand in hand with our partners at SAMHSA as well. So looking forward, and I hinted at it a little bit, we have a robust model pipeline, new models that we want to launch in the next couple of years that I'm not allowed to talk about. But we continue to examine gaps in areas in need of innovation that are kind of consistent with and support that vision and strategy that I laid out. And so would welcome any thoughts from you all as we move forward in our work, especially in the behavioral health space, for what's needed on the ground and how a place like the Innovation Center can hopefully help support and accelerate a lot of the transformative work that you all are engaged in already. I think one of the things that, like, kind of the point of overlap between our work and the work that you are all doing is value-based payment. I know there's a session on value-based contracting as well. And I really think of value-based contracting or value-based payment, value-based care, whichever acronym you want to use for it, is that it's not the end goal. It's really the mechanism, right? It's the means to the end, which is to really reorient a health system that's very fee-for-service based to one that's more patient-centered, by looking at the kinds of outcomes and goals that we want to be able to achieve for patients. So I'll stop there. I don't know if I've gone over. We're good? Okay, yeah, so we can do a little Q&A if folks have questions. I'll do my best to answer.
Hi, how are you? I'm from New Jersey, and I'm in a county that's piloting the Inc. model. So I'm curious, we have a pretty robust system of care in New Jersey, and the Inc. model is similar to our system of care. And so I'm wondering how CMS and the Innovation Center is the plan to integrate these into the existing models, to replace them, to just make it kind of a collaborative effort? Like, how does that work with these new models that almost duplicate the existing system but take it to the next level? So what's the end goal?
I think that's a really good question, and one that we're working through on some of the future state-based work we want to do, because and this is what's tricky, it's almost, if you look historically at the work that the Innovation Center has done, we've done much more in the Medicare space, because we have honestly more payment and regulatory flexibility, but because we're also dealing with one program, right? When we're engaged in state and Medicaid work, it's exponentially more complex. So your county in New Jersey may be better set up than another county in New Jersey, and it's the state that's making the decision to come in. And so we're grappling with this on some of the future work that we want to do. And what we want to be able to do, honestly, is if you're doing that great work, is there some way for our model to better support the work that you're doing? Does it allow you to accelerate any of the work that you're doing? And so the one way to think about it, and I don't know this totally holds for Inc., but you have a core set of services, and maybe you're already providing those core set of services, but do the additional flexibilities or supports in a model allow you to provide those optional services, right? Does it allow you to reach outside of the work that you're doing? I think for scaling, it's, again, trickier in Medicaid, but there is that heterogeneity. And so when we get multiple states in a model, I think it's also really helpful for other states to see, to benchmark themselves against, a New Jersey or a state that doesn't have experience, what worked and what didn't, if that makes sense. So I don't think there's, especially in the state work, would never see a scenario where we want to replace anything that's working, really integrate, hopefully lift up and create a new floor for everybody through the innovation, hopefully.
Hey, I'm Teresa Waters, and I'm from Kentucky. I can proudly say that. One of the things that's really interesting and challenging about system transformation and alternative payment models that shift risk is that a lot of areas, the market isn't there, the providers aren't there, and so it's very thin. I remember talking to our state Medicaid program about, addressing needs for patients with social determinants of health challenges. And they said, yes, we're working with all 3 of our beneficiaries in this county, right? So because there's 6 Medicaid programs, they're statewide. So nobody has the critical mass to serve and the ability to absorb risk because of size. And I think that's a major concern. How do you guys think about that, and what are you doing?
I think it's a really tricky issue, especially when we have these goals around equity, because we're trying to reach those beneficiaries, and if they're in rural areas, there isn't that scale. Even in urban areas, if you're a health system or a primary care practice or physician group practice in an underserved area in an urban area, you don't have the capability to take on risk. We're learning that a lot in our work and discussions right now with HRSA and on the community health center side, that we really, financial risk, again, we need to be thinking about it as a mechanism for transformation. With that financial risk should come flexibilities to be able to provide the care that you want to provide, and there have to be different levels of risk. And risk may not work for everybody, but we do know that some risk and accountability does tend to, is related to care delivery transformations. We know we need a little bit of it, but we have to find the right amount. In terms of, I think the workforce issues are probably one of the biggest issues. I had a colleague that was out in West Virginia, our chief medical officer was out in West Virginia on Monday, and I was catching up with her after, I was like, how did it go? And she's like, it just helps so much to get out there on the ground. She's like, I just heard about workforce all day. And here I am talking about like payment models and regulatory flexibilities, but it's the workforce. We get a lot of stakeholder meetings, and that's actually a big question I've been asking, especially in the behavioral health space, where we have all these ACOs and others coming in with us talking about their their behavioral health programs, and I've just been asking, well, how are you staffing them? I think there's a huge move towards telehealth, telepsychiatry. We're seeing a lot of folks leverage those kinds of technologies. There's also a lot of training I think there's a new openness to thinking about the workforce more broadly. So for instance, like nurse practitioner benefit enhancement. I just spoke to a group last week in the behavioral health space that was talking about, peer-to-peer support. And none of this is gonna be new to you all, but being able to more deliberately leverage and train more people to do this work, especially if they're from the communities that they reside in, I think is really important. I mean, community health workers are another place where we're doing a lot of thinking and work about how do we create models that allow for sustainable pathways for community health workers as well. But I think these are great questions. So I think risk we have to calibrate it to and then the last thing I'll say is aggregators. I don't know if this is good or bad, but there are a lot of entities out there now that are identifying those practices that may not have the critical mass. They're in rural areas, but we know they need the infrastructure and support. And so there are large organizations that go and find these practices and help them develop accountable care capabilities as well through infrastructure. And in many cases, those organizations are the ones that are assuming the risk, not the individual practices, is what we're finding, especially in the primary care space where your average practice can't do that. Thank you.